We are excited for our first plenary speaker. Dr. Carolyn M. Tucker is the UF Florida Blue Endowed Chair in Health Disparities Research at the University of Florida. She is a distinguished alumni professor, a research professor in psychology, and a courtesy professor in community health and family medicine. Additionally, she is the director of the UF Health Disparities Research and Intervention Program, director of the UF Health Cancer Center Cancer Disparities Research Collaborative, and the Cancer Control and Population Sciences Liaison to Community Outreach and Engagement at the UFCC. She is also a member of the Board of Directors for the Florida Community Health Workers Coalition and serves as the co-chair of its research subgroup. Dr. Tucker is nationally and internationally known as the founder of the evidence-based Health Smart Behavior Program, trademarked, to prevent and reduce obesity and related diseases, called Health Smart. The published child and adult versions of her Motivators and Barriers to Health Smart Behaviors Inventory and Health Smart are landmark health promotion and health equity tools.
One love, one heart, let's get together and feel alright. I was invited to go to Cape Town, South Africa, to talk about conducting community-based participatory research to address HIV and AIDS. But what happened is I was reflecting on the townships where the people were very poor, the blacks in Cape Town. And, and I looked in the audience and I didn't see any of those persons there, those who were living and experiencing that. And so I got up to give my talk and I didn't give it. And I shared the words that were dancing in my head and my heart. And the audience joined in, and everybody was crying. They got it, right? We had left out the most important people. And so that's really what started me on the journey in terms of my approach to addressing health disparities and to all of the work that I do.
I met Dr. Tucker through my church, which is Bethel Baptist Institutional. She came to our church to introduce a concept with regards to Health Smart for families.
The idea, number one, of having an ongoing program that worked directly with individuals who happened to be partnered with churches, and the idea of building long-term relationships with pastors and churches. That kind of thing was not common at that time, still isn't today.
Her innovation really is to have taken evidence-based approaches to improving nutrition, improving exercise, working with communities to figure out the right language and the right way to describe those interventions in ways that seem positive and proactive, and then working with church communities as one example, like the church behind me. For the program to be successful and sustainable, she needs to recruit members of the community themselves to become change agents, and that's what she does really well.
Even though we've had different experiences, we're all similar, and we can share those things and be encouraged by it.
When I go to the doctor, I have a journal right in here that I open up and then know how, where I am, what's going on.
So she has done a wonderful job in giving us the courage to speak up to our doctors and ask questions from our doctors and just be empowered when we go to the doctor's office.
Dr. Tucker is a change agent, and she helped us to get over those first hurdles. And we've all stuck together. We're not under a grant now, and it's been about 18 months, all because of the seed that she planted, starting with Health Smart. and we're remaining health smart. Amen. Well, come on, let's.
Okay.
Food is a big thing in predominantly African American communities, and the idea of changing the way that food is seasoned and how food is prepared, I thought that that was going to be like pulling teeth. It turned out to be the absolute opposite.
You know, I think I'm just most proud of developing interventions and having community members to implement them to try to address the hypertension, the diabetes, cancers that are disproportionately high in Black and low-income communities. And when I see, for example, Health Smart, it just makes me jump for joy. And you know, it's being used nationally and internationally.
The evidence that has been produced by Dr. Tucker's research is indisputable.
I didn't just sing it in South Africa. I sing it at every one of our Power Over Cancer gatherings. And then I ask people to always have an ear for the beats of different hearts.
Please give a warm welcome to Dr. Tucker.
Wow. I am so excited to be here today. And if my grandfather were here, and I do feel his presence, he's passed, but he would say she's tickled from the top of her head to the bottom of her feet. And my father would say, her cup runneth over with emotion. But I think the best way to tell you how excited I am to be here with you is to simply say that I am just tickled black about it. So thank you to everyone who invited me to come. So very often, folks ask me, what is the inspiration for the work that you do? And actually, let me go back and tell you, I think everybody knows in terms of what I'm going to talk about. But the title is Reducing Racism-Related Health Disparities with an Ear for the Beats of Different and Wounded Hearts. Now, I was getting ready to say, people ask me all the time, what is the inspiration for the work that you do to address racism-related health disparities? And so one of those sources of inspiration is becoming woke to the facts that the social determinants of health that we always talk about as being used to explain health disparities are all really anchored in racism. And so whether we're talking about poverty or access to health care or access to insurance or education, all of those. And so this racism is evidenced by the discriminatory practice of redlining that occurred from 1933 to 1968. And this redlining involved not giving governmental loans to people living in communities with a large percentage of Blacks, Hispanic Latinos, other brown people. And these communities, interestingly, were identified by red coloring on the US map. And those communities that had mostly white people were colored green on the map. And then not locating businesses, hospitals, or supermarkets in these red-lined communities. And what's interesting is that the impact of redlining still lingers today. In the community where I work, the low-income area of Gainesville, Florida, we don't have a hospital there. We didn't have, until very recently, a food store. And right in the actual area of the community, there is no supermarket. So redlining in some form still exists. Another source of inspiration is growing up in a poor, rural Black community plagued by health disparities and racism, reading about Mrs. Fannie Lou Hamer, a poor Black woman activist who inspired others to fight against injustice with these words: "Now I am sick and tired of being sick and tired of just talking about injustice." Well, I became sick and tired of being sick and tired of just talking about rather than doing something about racism-related health disparities. And then hearing Supreme Court Justice Ruth Bader Ginsburg say, "All I ask is that they take their feet off of our necks." And these words inspired me to develop interventions to empower Blacks, Hispanic, Latinos, and the medically underserved to take charge of their health under whatever conditions that existed in their lives. And also reflecting often on the words of my grandfather, Deegan Roy N. Tucker, who told me ever since I was 7 years old, anything worth doing ain't easy. And anything worth having is worth working hard to achieve. And I used to tell him, "Grandfather, it's just so hard. You know, everything I'm doing is just so hard." And then he said, "Hard? Let me just tell you about the fact that I used to walk 7 miles to school and walk 7 miles back, and you talking about you tired?" Okay, so I decided that working hard to reduce racism-related health disparities is indeed worth doing. And then hearing older Blacks pray in my community that racism-related health disparities will be eliminated. And I'm a strong believer in prayer. But you know, I later read the famous words of Ms. Fannie Lou Hamer that you can pray until you faint. But if you don't get up and try to do something, God is not going to put it in your lap. And then reminding myself of the meaning and levels of racism-related health disparities and of the evidence that these disparities exist. Because a lot of people tell me they don't. So with regard to the meaning of racism-related health disparities, basically there are unjust differences in health behaviors, statuses, outcomes, and healthcare access between non-white people and white people due to racism. And racism is a social system that considers and treats non-white people as inferior and or non-human with the aim of disempowering and disenfranchising them. Now, let me just pause and say, because I don't want anybody to get upset with me, there are a lot of good white people that I like a whole lot, okay? I thought I'd better say that, okay? So now I can move on, okay? So with regard to the levels of racism-related health disparities, there are four. One, the individual level, and that's like having negative stereotypes of Blacks that impact all aspects of their lives, that they're unintelligent, lazy, threatening. And I'll provide you some evidence of this as we go along. And then there's the interpersonal level, dismissing the pain of Black patients by doctors. This still happens. And the cultural level, disrespecting traditional healing practices. And then the system level, not placing healthcare sites in Black communities, and I'm sure also in some brown communities. And so with regard to, I want to focus mostly on system level and individual level racism because those are most resistant to change. So some of the evidence with regard to system level racism-related health disparities is research showing that racially segregated Black neighborhoods typically receive less funding for health care than other neighborhoods. Research documenting that racialized minority healthcare staff experience racism from their patients and their colleagues, but they don't talk about it. So they don't want to share it. And there are usually no vehicles, no policies, no organizational structure to deal with the racism or for them to have some conversation. They are uncomfortable. People are uncomfortable talking about racism-related anything. But one of my graduate students told me, Dr. Tucker, you have to get comfortable with being uncomfortable. And so here's some evidence of the individual level racism-related health disparities. So I want to talk about stereotypes with regard to African Americans that was identified in what I call the Tucker's informal word association test that was administered to about 1,000 students, culturally diverse students, and about 400 diverse faculty who were mostly white. And I just simply said, I want you to tell me what words have you heard other people say, other people like your family and friends and your neighbors say about African Americans. And these are some of the words that were shared. Lazy, smell bad. And let me just stop and say, everywhere I travel, I usually take the opportunity when I'm presenting to faculty, and I'm talking about some topic related to what I'm talking about today, and I ask them the same question, and it's been consistent. These are the consistent words. I don't care what state I'm in, okay? Lazy, smell bad, unintelligent, inferior, rowdy, aggressive, muscular with regard to the women, low class, unprofessional hair, sassy, unattractive, dangerous, uneducated, illiterate, athletic, tolerate pain, disrespectful, angry, strong, sexualized, vulgar, hypermasculine, protective, and ghetto. The one word that what I didn't say is they did say we can dance. And we can. So I'll just move right along. Okay, and maybe I will say that I also, and I want to ask you, see if you can help me here. We also asked, what words have you heard in association with the word Asian? And we did Hispanics as well, Hispanic Latinos. And there were some negative words, but there were more positive words than negative words. So, and I didn't show those just because I have a lot to cover. But I'm just asking if anybody is bold enough to tell me, if we could take just 30 seconds, when you think of the word Asian, what words come to mind? Anybody? Pardon? Educated. Smart. Industrious. Polite. Polite. Okay? And so all of the words that you're saying are words that I had on my list with regard to Asians and the model minority and good at math and on and on and on. They were very positive. There was one negative, smelly. I don't know where that came from, but moving right along. But you can see the differences between the stereotypes for blacks or African Americans versus Asians. So I'll move right along. Then there's evidence with regard to disease disparities, and we all know, I'm just selecting some evidence. So with regard to obesity disparities, black women compared to, there's a higher prevalence of obesity among black women compared to Hispanic women and white women. But you can see for all of the groups, this prevalence of obesity is too high regardless of which group. But black adults have a higher prevalence than Hispanic adults and white adults. And hypertension disparities, black adults, higher prevalence of hypertension, even diabetes. Blacks are leading the way. So it's a higher prevalence of diabetes compared to Hispanic adults and white adults. And I was careful to go back and make sure I got the most recent data that I could find to share with you. And so then there's evidence of racism-related health outcome disparities. Now, even though black women and white women have similar rates of breast cancer, black women are more likely to die from this cancer. And it's not because they're black, right? It's because all of those social determinants of health that come with being black, okay? It's nothing about the genes. Black women and Hispanic women have the higher rates of cervical cancer than other racial and ethnic groups of women, but black women are more likely than all other women to die from this cancer. Black men are twice as likely to die from prostate cancer than white men. And it's really interesting here that when I talked to some of my physician friends, they actually told me that they were uncomfortable touching black men, particularly in their private parts. I mean, I didn't believe it, but when you hear it over and over, you understand. This is how it is. Okay, so with regard to healthcare use disparities, black patients utilize in-person healthcare less than do white patients. Blacks are less likely than whites to receive telehealth care. So in the county, I also do work in Duval County, and we had 80% of whites were using telehealth and only 20% of blacks. Black communities are more likely to experience heightened barriers to healthcare access. So not having available healthcare that they can get to, not feeling comfortable that the places have people who look like them, and on and on. Now, there's also evidence of heart-wrenching racism in healthcare. And it was interesting to me how you were talking about the past. And so there were, in the past, performing of painful and inhumane surgeries on enslaved black women and adolescents without their consent and without anesthesia by Dr. James Marion Sims, who was called the father of modern gynecology. And it's interesting that Dr. Sims did these surgeries for, I guess it was 5 years on 12 enslaved women, that the enslavers gave him permission. They just turned these women over to Dr. Sims. And these were women who were experiencing vaginal fistulas. And so it came with a lot of pain and was from having very difficult pregnancies. And not only were these surgeries occurring without anesthesia, and the reason, again, was because they thought that blacks did not experience pain. And what Dr. Sims did was to strap them down when they performed these surgeries. There were white physicians around observing, and they made sure that all of the surgeries were done with these women being naked. And so he perfected this and with Anaka, which I want to say something about in just a moment, but he performed 30 surgeries on this one enslaved person, 17 years old, when the surgeries started. And he perfected them so he could do them with white women with covering over them and with anesthesia. Okay. And so this all has brought a lot of tears to my eyes. And I just want you to hear their names, because these could have been your children or grandchildren. Betsy, and they're not sure if if she was 17 or 18. Lucy, 18 years old. And Anaka, 30 surgeries, no anesthesia. So maybe hearing this, we can understand when blacks say they don't trust the providers, they don't trust healthcare sites because they read, they know. And so then I'll go on to the second study that everybody knows about, the Tuskegee study, right? And this is where there was a withholding of treatment for syphilis for 600 black men with syphilis who were in the Tuskegee study. And this went on for 40 years. And most of these men died. And many of the wives and children of these black men also got syphilis. And even though penicillin was available, they wanted to see what was the trajectory of the disease without it being treated. And these black men did not know that they were in the study. Now you can understand why even now it's hard for me to get even 14% of black men to participate in healthcare research. So I'll move on. And then there is also evidence of heart-wrenching racism in healthcare in recent years. Research showing that healthcare professionals and medical students still, not all, but some, still hold false beliefs about the biological differences between blacks and whites that result in racial bias in pain treatment by these providers, ignoring pain reported by black patients. And these patients tell me this, prescribing less pain medications to black patients than white patients. And you notice everything I'm talking about, I actually have the references. So you'll have the references, I have the citations, and you'll get the references. Research studies showing that racialized minorities are more likely than whites to report perceived racism in healthcare. And research showing that Hispanic and Latinas and other women of color report being scolded and treated rudely by some healthcare staff. Even though Hispanics and blacks have the highest risk of stroke, they are less likely to be prescribed stroke prevention medications than whites. And there's also evidence, heart-wrenching racism in healthcare with regard to the research showing that blacks underutilize available healthcare due to perceived cultural insensitivity of providers. And the studies that I've done with my team, I've highlighted, I've bolded. And also that lack of trust of providers due to fear of healthcare discrimination. And then there's research that's showing that the most vulnerable populations, including black older adults with multiple diseases, have been left out of the move to using telehealth, but these populations want to be able to use telehealth. And then there's also evidence of heart-wrenching racism-related mental health problems among African Americans. And so there's the existence of post-traumatic slave syndrome. And I'm gonna tell you, 2 years ago, I did not know what that was. I had never heard of it. But I was training some youth who are 16 and 17-year-olds to be mental health support persons for their peers. And during the training, I personally did this training. And one of the black guys who was 16 years old said, "Dr. Tucker, you don't understand. You just don't understand that we black guys and some of the young ladies, we're experiencing post-traumatic slave syndrome." And I was going, and I said, I've never heard of that. But then I immediately read about it. So it's a term coined by Dr. Joy DeGruy to describe mental health problems among African American children and adults that are due to multi-generational oppression from their African ancestors being subjected to chattel slavery. and institutionalized racism that continues to perpetuate injury and wounds without the opportunity to heal or to access the benefits given to majority Americans. They don't have access to mental health care. They can't afford it, right? It's not even available. Even in this nation, the number of people who are Black clinical psychologists, and I am a clinical psychologist licensed in Florida, that you can count on your fingers and toes combined. That's it. So, and the examples of the, and then with regard to being the last to get hired, as they were talking in terms of this Black male, 16 years old. And so some example problems are hopelessness, depression, feeling oppressed and broken, and self-injury. And this is one of the reasons that suicides among Black youth has continued to increase, and it's increased quite a bit in the last 2 years. And then I have to tell you the story of Mary, who is also in this mental health support training program that's in progress now. And so Mary told me, this is a fictitious name, but Mary told us that she had experienced racism-related stress as well as depression a year ago, and that she asked her mother to get counseling, but her mother told her that going to counseling is not something that Black folks do. And so there was a stigma which still exists in many Black communities, particularly those that have lower incomes. And so she later talked to her school counselor, and she told her school counselor that she felt broken. And then her counselor talked to her parents and convinced her parents that she needed some counseling. And so Mary told me that after she received counseling, that now I know that broken wings can fly. And I can't tell you, I actually have given a talk on broken wings can fly. This sticks with me. And so now I want to move on to talk about 3 grant-funded intervention research programs to help reduce racism-related physical and/or mental health disparities. And these are 3 programs that I direct. I could have chosen others, but I was inspired to choose these 3. So one is the patient-centered, culturally sensitive healthcare program to reduce obesity among Black women primary care patients that was actually done in primary care settings. And then the Health Smart Holistic Health Program to increase health-promoting behaviors and reduce stress, depression, and food insecurity among older Black adults in a low-income community. And then the pastor-led mental health program for improving quality of life among Black older adults. And so I want to, before giving you basically what we did and what we found, which I'll do very quickly, I want to talk about the characteristics of all 3 of my intervention research programs and of everything I do, including the Cancer Disparities Research Collaborative, okay? So they are all anchored in the community-based participatory research model, which I'm sure all of you have heard of. And so this model requires researchers to involve community members as equitable partners in all research components. So I have community members on my team who also are on my publications. They make meaning of the findings. I tell them the findings. They recognize community members as experts. I recognize, my team recognizes. Also, it requires that you promote community empowerment through bringing resources to the community. So you know how at universities, I know some of you are at universities, and how they get all of the grant money. So I bring in a grant, they get 56%, the university. How much goes to the community? 0. Or if you set up a health promotion program, find some way to make sure it's sustained. We can't do helicopter intervention research, right? We get our data and then we're gone, and the community is not left with anything. Discuss findings with the target participants and their community. And we always hold town hall meetings. And this is where you can find partners, because people who are interested in whatever it is you're talking about will come. And so I've even gotten a funder just because they came to the town hall meeting to find out what did we learn from our research. Also, all of my research is anchored in the difference model rather than the deficit model research approach. Difference model means that you can study a particular community. So if I'm studying lower income blacks, right, I want to know why some of them do better than others. But deficit model is what we've been doing all along, which is comparing people of color with white people. And that's the deficit. And whenever you do that, we're going to always look like we're doing worse. But that's because we're not considering the cultural context. Involve students as research interns or assistants. We include technology training for the participating community members. And that is so important because, for example, with the pastoral program that I mentioned, it's all done via Zoom. And even HealthSmart now, we do it via Zoom. And people tell me, oh, well, these lower income black folks won't learn how to do Zoom. We prove them wrong, okay? And then utilizing community settings. So my research is either done in churches or we do some in barbershops, right? And beauty salons. You take the research to where the people are. And so that means whatever you're doing can be sustained because the church is not going to go anywhere and the barbershop's not going to go anywhere. And we also always have a community advisory board because that's the board, for example, will tell me, how do we engage black men? How do we engage Hispanic men? Okay? And then it's also all of the studies, all of the research is implemented mostly by trained communities who recruit, enroll, and collect data from participants using iPads. We call them all community scientists, which is an empowering term. I had to fight with the University of Florida's Institutional Review Board because they had to go through the IRB training, right, to be able to have access to data, and everybody told me that we just couldn't do this. We did it, and they are hired as unaffiliated investigators. We conduct the intervention components are conducted by health empowerment coaches. We have community program managers that are hired. They are paid much more than a minimum wage. And everybody with whom I work is trained in cultural sensitivity versus cultural competence. Cultural competence is having the knowledge, skills, awareness, and experiences to interact with people who are different, to treat patients who are different from yourself. But cultural sensitivity is what I call cultural competence plus. But you can have all of the knowledge in the world, but if you don't convey that you have this competence in ways that enable others different from you to feel comfortable with us, respected by us, and trusting of us, then you can just forget it. If they don't trust you, they're not going to do whatever you prescribe or recommend. Being aware of and accepting of cultural differences. This is cultural sensitivity. Being aware of and trying to rid ourselves of our racism-related biases and stereotypes, and we all have them. Just being aware of them. And then empowering those in relationships with us to have or perceive, those who perceive that they have less power than we do, then we want to empower them. And so, for example, we can empower our patients by asking, listening to, and acting on their opinion. Now, listening is a big deal issue. I did a training for a large group of physicians, primary care physicians. And so one of the first questions was, well, Dr. Tucker, how do you show that you are listening to the patients? So I want to ask you, how do you show that you are listening to a patient? Anybody is bold enough? Eye contact, that's definitely one. Paraphrasing or restating what the person said, because they know you heard them if you can restate it. Anything else? Lean forward. Who said lean forward? Oh, wow. Okay, exactly. That's right. Okay, and lean forward. So, and you can say, I hear you, right? Okay. So it doesn't take a mastermind, but I can't tell you how many people who told me, they said, well, we weren't trained in how to listen. And also just think about how many of you are in relationships. You're dating somebody or you're married to somebody. Would you put your hands up? All right, that's a lot of people, okay? Now, how many of you think you listen to the people that you're married to or dating? I didn't see a whole lot of hands. I'm visually challenged, but I didn't see a whole lot of hands. All right, I think I made my point. So I'm going to go on. So I want to talk about the patient-centered culturally sensitive healthcare program to reduce obesity among Black women primary care patients. And basically, I wanted to define what this is, patient-centered culturally sensitive healthcare, which I've written a lot about. It involves assessing views of patients regarding provider and office staff behaviors that promote their feelings of comfort, trust, and respect. It conveys an understanding that the patient-provider relationship is a partnership. It is patient empowerment oriented, and it is reflected in physical healthcare environments, staffing, and policies that promote feelings of comfort, trust, and respect. Because we already talked about what has happened historically. A lot of folks don't trust healthcare providers, okay? And so I won't go through all of these. Well, maybe I'll just mention them quickly. I have developed and published inventories, so an inventory for patients to evaluate the cultural sensitivity of providers, an inventory for patients to evaluate the clinic environment, an inventory for patients to evaluate the healthcare office staff. And I must mention that because of what we learned, and this is from a national study funded by the Robert Wood Johnson Foundation involving 63 healthcare sites across the nation. And so that's the data that we use to develop these inventories. And so, but it was interesting that they had more problems with the front desk office staff than with the providers, which was interesting to me. And so we developed an inventory for assessing their cultural sensitivity. And then we have one that they can evaluate themselves. The providers can evaluate their own sensitivity. And so this is important because those evaluations have implications for what you can change. Okay? So why do this study? One, that we conducted a study that involved 520 culturally diverse patients from among 39 primary care clinics in Jacksonville, Florida. And we simply asked these patients about their perception with regard to the frequency with which their physicians talked to them about managing their weight or obesity. 45.8% of the patients said that their doctors never or rarely talked to them about their weight or managing it. Only 19.8% said that they frequently or very frequently talked to them about their weight. And then we also did a study with 25 physicians. It was a small study. 80% were white. And they were from among these same 39 primary care clinics. These were the 25 who agreed to participate, and some of the clinics did not have a provider because some providers went to more than one clinic. But 24% of these providers reported discussing healthy eating and physical activity with their patients. 20% said that they rarely tracked the diet, the physical activity, or weight of their patients. Yet it was mandatory that they do these things. But 88% said that they should discuss these topics with their patients. It just wasn't happening. And so there are a lot of reasons that we could come up with as to why that is, right? So very often it's not having the time. Okay. So, I went ahead too fast. Okay, so now I want to just talk about the components of, for the research aspect of this. So we integrated 13 Black women community health workers into 20 community primary care clinics. And then we had these CHWs to implement Health Smart with 441 target patients who were Black women, primary care patients who had obesity. And then we conducted focus groups with Black women very much like them to identify culturally sensitive physician behaviors when talking to Black women about their weight or obesity. So we did, this is the qualitative data. And then we trained the physicians, 10 of them. We randomly assigned 10 clinics along with their physicians to standard behavioral weight loss maintenance, motivational interviewing. But what was more important is that we trained physicians at the other 10 clinics to implement the patient-centered, culturally sensitive weight loss maintenance. Now the reason so first with Health Smart, we just got them to lose weight, right? And then the issue was maintaining the weight, so we want to engage the physicians in helping them to maintain their weight loss using 2 different approaches. And I wanted you to just see some of the community health workers. This is 8 of the 13, just regular people. Okay, and I want to share with you the findings. So first of all, from the qualitative focus group data, this is what the Black women said they wanted their doctors to do or not do. Show respect for the patient's religious beliefs. Chat about the patient's week and family before focusing on their weight, before sticking a thermometer in their mouths. How's your husband doing? I know he had surgery. How's that job going? Your new job, showing that you know something about the patient. Be compassionate, sensitive, and understanding. Just say, I hear you, I care. This is what the women were saying. Say you want to earn the patient's trust. Just say that. Just say one line. Give a lot of encouragement and praise for efforts to lose weight. I was amazed. I just could not believe how important it was for the doctors to praise their patients. I said, I'm really proud that you are trying, even if you haven't lost a pound. Just say you're proud of their effort, and that's encouraging. Ask patients how they want to be addressed. And I know that one of the members of our community, Mrs. Vivian Fowler, was saying, and I think she's now 84, and she has been saying, though, for the last 10 years, that you don't have the privilege to call me by my first name. You don't have the privilege. And so unless I tell you that you can call me by my first name, then you don't have the right or privilege to do so. So it's important to ask your patients how they want to be called. And that's why when I meet people, I always say Mr., Ms., Doctor, whatever, right? Because I don't feel like I have the permission to call them by their first name until they give me that permission. And then listen more and talk less. There are plenty of studies that show that physicians talk more to Black patients and they listen more to white patients. And do not talk to the patients like they are children or illiterate. Don't make assumptions about Black women that just because they are heavy that they eat a whole lot of food. Tell them the side effects of medications, including weight gain. A lot of them were saying, I'm eating less and I'm exercising, but I'm not losing weight, and then found out that the medication they were taking was causing weight gain. Ask what support is needed to help patients reach their goals. And the physicians who were in our study said, oh my God, you know, I never thought to say that. What can I do to support you? And then treat Black women patients the way they say they want to be treated, not treat them like how you want to be treated. Okay. So, and we, as I said earlier, we've published all of this. And so then I just wanted to share with you the people who were in the study. So as you can see that they were the two groups, the standard behavioral or motivational interviewing group, the patient-centered culturally sensitive group, and the only thing that these people got, the patient-centered culturally sensitive, was I only just went over those behaviors that I just went over with you. I taught the doctors just to do those things and to say those things, okay? And so, and you can also see that 70% had more than a high school diploma. However, 53.8% or 55% had incomes of $39,999 or lower. That's household incomes, okay? And so I just wanted to show you this chart. This is the percent of people who lost 5% of their body weight that's supposed to be clinically significant. And so the Health Smart was done in the first 6 months for each group, and you can see that the ones who got the culturally sensitive training, more of them lost 5% of their body weight than those who were in the standard behavioral. But what I really want you to see is look at the red bars. The red bars are the ones who got their doctors started being culturally sensitive. And you can see about 50, I guess it's probably about 55% or 54% lost 5% of their body weight. That's a lot compared to those who got the standard behavioral weight loss maintenance, their doctors. You can see that there's a significant difference, that the culturally sensitive group had more people who lost 5% of their body weight that's considered clinically significant. And then you can see it even better here. So the line, that's the one line, that's all of the people together across all of the clinics. During Health Smart, you saw the weight loss. And then after the 6 months, then you can see what happened with the two groups. The culturally sensitive group, right, where their doctors were culturally sensitive, they kept losing weight over a whole year, which is amazing. And we published this in Clinical Obesity. Okay, now I'll talk about the other two programs are very short. So this Health Smart Holistic Health Program to increase health-promoting behaviors and reduce stress, depression, and food insecurity among older Blacks and a low-income community. And so this was conducted in Health Zone 1 of Jacksonville. There are 6 health zones. Health Zone 1 has 79% Black, has the lowest incomes, the highest chronic diseases, and also the higher death rates. And so we implemented this program in 20 Black churches, 2 community health centers where people could just walk in and get their blood pressure checked, and 2 senior centers. And so there were 139 seniors, and 85.6% were female. All of them were Black or African American, and they had incomes below $29,000. This is household incomes. And 80.6% had those low incomes, and those who were living without a spouse was 66.9%. And so I just want to show this one slide to describe this whole program. So first of all, there are multiple issues that influence people's engaging in health-promoting behaviors and their stress and all of this. So we implemented Health Smart for 10 weeks, and it's 2 hours per week. We had a physician prescription of Health Smart program, and they prescribed people, this was 4 UF Health affiliated primary care clinics, community-based clinics. They referred patients to Health Smart. And then training and use of our social connection, food security, and mental and physical health promotion app, which I'm so excited about, so that we taught the participants to chat with each other using the app. But the other part is they could post their mental health questions and their physical health questions. Now, all of the things I'm talking about blacks, but it could be Hispanic, Latinos, it could be any group, right, or any lower income community. And they would post their questions about stress or their questions about depression or whatever. And we had a board of professionals who would answer the questions. We posted without your name, and you could go on and see what the question is and what the answer was. And then we most all the time referred them to a place where they could get health care at low cost or scale to income. And then there were 20 Health Smart church pantries. I never thought that as a professor that I would be establishing food pantries. That was not on my list of things to do, okay? But we did. And then also work with the Jacksonville Transit Authority to change policies. Never thought I'd be doing policies. So we organized the community to form an alliance, met with the Jacksonville Transit Authority, and I just wanted to give you one example of a policy change. We found that through redlining many years ago, that the buses in Health Zone 1, the low-income area, for you to go to the nearest food store, supermarket, and come back, it took 5 hours. Now, you know your milk could have spoiled by then, being in Florida, right, in the summertime. And so, yet, that's the way it was. We lobbied, we was the community. I participated, but because I got the JTA to listen, right? They changed the bus route so that they had multiple buses going to Walmart, because that's where they could get their groceries and their prescriptions filled and all of that. But you see how, and it really changed their quality of life, okay? And you can see in the picture, the one that's with the people eating with the food, that was at one of our town hall meetings where we gave them the results of our study. And then you can see my students working with teaching folks. I think I might have skipped over. We taught them how to use their smartphones. And I have a big project starting in Alachua County in Florida, where I live, teaching seniors how to use their smartphones, how to use Google to look up what is osteoarthritis. Are you with me? It's empowering them with health knowledge. And also they want to know how to chat, how to take pictures and send them to their children, right? Whatever they wanted to learn, my students were teaching them. And we're now doing that at several churches. And at the bottom, you can see them dancing. And then with regard to the pantries, we work with the Feeding the North Florida. And first, they had to go to their storage place to get food. And so we got them to bring the food out to the different churches, and people could come and get the food. Okay. And so I wanted to show you the findings. So the change in food insecurity, and you see 3 data points. 1 was before this program started. 2 was right after the end of this program, and we repeated this with several hundreds of folks, but I'm just giving 1 data set. And then 3 months later, where there was nothing was happening, we want to see would it be maintained. So you can see food insecurity went down, right, and stayed down for 3 months, meaning when we collected data 3 months later, okay? Depression, and all of these are statistically significant. Went down, went up a little bit, but not way where it was, okay? Stress went down, stayed down. I feel like this is unbelievable. Change in loneliness went down. They were using those smartphones, right? And BMI went down. So from time 1 to time 3, it was statistically significant. And then lastly, the pastor-led telemental health support program for improving quality of life among older Black adults. And so this is the one slide that I will share. So what we did here is, pastors are trusted people. So we work with 28 Black pastors and church leaders. So usually it was a pastor and then somebody the head of the ministerial group from among 14 churches. We had a total of 259 older Black church members who participated in this program. And so in terms of the components, the Black pastors were taught via Zoom the skills that I actually teach patients, right? Skills for managing stress, skills for managing depression, managing anger, managing conflict, and grief. And we called them pastoral mental health support coaches. Now, when we did this training, I don't know if I don't know if I just looked like somebody that you could trust, but they were just opening up, right? And we had pastors crying on the Zoom about their own stress and depression. We were teaching them how to teach their congregants, right? But they had all kind of issues, right? And, and the literature indicated that for pastors, 80% of them are 70% in marriages that there's not happiness because they're focusing on the congregants, not on their partners, right? And then they had a lot of stress in terms of just, they had their own stress issues, and then they had the stress of all of their congregants, right? So we didn't expect the impact it was having on the trainees. But then these coaches used Zoom to teach their congregants what they had learned. And we had a training guide with the skills and the related scriptures. It took me 2 years to find scriptures in the Bible that had something to do with stress, depression, but it's there, okay? And we even asked the bishop, and he didn't know. But we found it, right? And so that made it a little bit more legitimate, right? And then the participants also, and we have these materials available, which we will be disseminating at some point. And then they got the same information, the participants, they just didn't get the discussion questions and all of that. Okay. And so the findings, and I'll be done shortly. The findings, you can see, and for this, it's social, health-related quality of life. That's what that is. And so we had, before the program, 2 weeks after the program ended, okay, and the program was three 2-hour sessions. That's it, over 3 weeks. 1 session each week, right? And so when they got through the sessions, the three weeks of sessions, we waited 2 weeks, and then we collected data, right? We gave them questionnaires. And then 6 weeks later, we collected data again. So it's really a total of 8 weeks from the intervention ending. And we got significant improvements in social health-related quality of life. We got significant reductions in loneliness. We got significant reductions in depression. Unbelievable. I think we've submitted this for publication. And significant improvements in physical health-related quality of life, headaches, stomach problems, okay? So now we've gotten to one of my favorite, almost the end. There's a test for you. It's called the Tucker's Readiness to Help Reduce Racism-Related Health Disparities Test. And it's a true and false questions. And you get 1 point if you say true. You get 0 if you say false. And you can get a possible 6 points. And if you get 6 points, you're ready to reduce racism-related health disparities. So here we go. You are willing to do something to help reduce racism-related health disparity. Anything. Who said false? Wait a minute, I'm having those auditory hallucinations again. Okay. All right, number 2. You will try to be culturally sensitive when interacting with folks culturally different from you. True or false? Okay. Seems like most people have 2 points already. Okay. You will try to provide, promote, or at least value patient-centered, culturally sensitive health care. True or false? folks in the back, what did you all say? Okay, I just want to make sure. Okay. You will consider engaging community members as partners and experts in your efforts to reduce health or healthcare disparities or to promote community health. Y'all got a little weak on me on that one. Let's try that again. Okay, all right. Now it's getting harder for the last two questions. Okay. When working with racialized minority patients, healthcare staff, and community members who experience racism-related health disparities, you will do so with an ear for the beats of different and sometimes wounded hearts. In the back? Okay. All right, now here comes the real hard one. You are willing to help Carolyn sing One Love, One Heart, Let's Get Together and Feel All Right. All right, everybody, I think everybody said true. Now, did anybody say false? Okay, so that means you're ready, right? You're ready to reduce racism-related health disparities. Now, I want us to sing, and let me tell you, if any of my students were here or my close friends, colleagues, they would say, she can't sing. And I know that I can't sing, but I'm going to sing anyway, okay? And I have practiced this line for the last 30 years, okay? Are you all with me? Okay, I have to clear my throat. And this is where it's going to go. I am going to sing it one time by myself, and then we will sing it together twice. Is everybody ready? Okay. One love, one heart, let's get together and feel all right. Got it? Okay. Well, wait a minute, we have to do it together. Okay, let's go. One love, one heart, let's get together and feel all right. Again, louder. One love, one heart, let's get together and feel all right. Thank you.
Thank you so much to Dr. Tucker for talking to us tonight. Something that stuck to me, you mentioned that a phrase got stuck to you, and tonight got stuck to me too. And that was broken wings can fly. And as today I was holding the tears as we were celebrating Illuminers, and I was just thinking, I'm here because of them. And they're passing the light to us now to continue. I wonder, and I really hope that this conference can help us heal the broken wings and even move forward and don't have broken wings, but instead empower those wings. So with that, I invite everyone to enjoy our welcome celebration, which is gonna happen at the end of this room, and enjoy the conference. Welcome to CFHA Conference 2024 in San Antonio. Thank you.